August BLS CME, high-risk chief complaints. We'll talk about fever and electrolytes. Objectives. We'll review the systematic approach. We'll review U1 protocol. We'll identify and recognize high-risk chief complaints. We'll discuss protocols and treatments, and we'll discuss pitfalls. Systematic approach to patient care. When we arrive on scene, our first thoughts are our general impression. We must first get a cardinal presentation of the patient, determine what our needs are going to be and how our patient is presenting. We will then move on to the primary assessment. From there, we will do our XABCDE. We will determine if the patient is sick or not sick, and whether or not we need to stay and play or load and go. Our secondary assessment is mostly going to be done in the back of the ambulance. That will be where we do our vital signs, our sampler, and our OPQ-RST. Finally, we reassess all of our patients to make sure that we get a second set of vitals, and then we also, any kind of interventions that we have done, that we're making sure that we're reassessing those interventions. The universal approach to patient care. We first must start with scene safety to make sure that the scene is safe. We then make sure that we have all of our equipment and our appropriate PPE. We determine the number of patients and additional resources we may need. We perform our full assessment, which consists of our primary assessment. And then we get our secondary assessment, which has our baseline vitals, and we determine whether our patient is a red, yellow, or green. We will use the pediatric assessment triangle for pediatric patients, as well as the HANTEVI book and the HANTEVI bag that we use. Indwelling external and also indwelling external medical devices. We will then move on to our treatment. This will be where we may apply oxygen with evidence of shortness of breath, ventilation assistance as needed, or utilize appropriate protocol as needed. We then will determine our transport decision. We use approved patient restraint devices. We transport our patients to the appropriate facilities and pre-arrival at bedside report. Finally, our documentation, which is also very important. We complete appropriate documentation, our narrative, which of course is in SOAP format. A fever is an elevation of core body temperature above a set point. Our body regulates our temperature through our hypothalamus. Normal ranges are between 96.8 and 100.4 Fahrenheit, or 36 and 38 degrees Celsius. A fever is not the same as hyperthermia. Fever versus hyperthermia. What can cause a fever? Well, mostly it's infections. What causes hyperthermia? Well, it could be trauma-related, it could be medication-induced, illicit drug use, the environment, or any kind of exertion. Assessment of complaints. We want to determine the difference between the core temperature versus the peripheral temperature. Of course, the core temperature being inside in the internal organs versus the peripheral temperature. How does our patient feel? Are they hot to the touch? How is the ambient temperature? How is the temperature surrounding the patient? Is it hot in there? Are we in an environment where it's extremely the heat? There's no air conditioning, things like that. And then what are they dressed like? Are they wearing multiple layers? Are they outside in the heat where they're wearing multiple layers? Those are all considerations. History taking. We must find out how long the fever has been going on for, any interventions they've done, for example, if they've used any ibuprofen, Tylenol, and then, of course, how was the temperature checked? What type of thermometer did they use? How did they check it? And then, of course, the symptoms associated with their fever. What else are they having? Weakness, chills, things like that. Referenced in your mom's protocol, M8 deals with heat emergency protocols. Referenced in your mom's manual as M8 is all the pearls. Also in your mom's protocol, M9 suspected sepsis. Suspected infection source, the criteria, has to be heart rate of over 100, a respiratory rate of 20, or an EtCO2 of less than or equal to 30. The systolic blood pressure is less than 90, or the capillary refill is greater than 4 seconds. Mottled skin, and of course, acute decrease in mentation. P18, pediatric fever, suspected sepsis. Criteria is as follows. Suspected infection source, tachycardia or weak thready pulse, tachypnea, EtCO2 less than or equal to 30, hypotension, capillary refill greater than 3 seconds, mottled skin, acute change in mentation, or any high-risk conditions.